Hi everyone, my name is Ruth Ann Matthew Karatil. I'm a first year internal medicine resident at Creighton University School of Medicine. My topic is on massive intractable pericardial effusion as an initial presentation of SLE. I would also like to thank Akshay B. Manchanhalli, without whom this presentation would not have been possible. Moving on to the case presentation, our patient is a 59-year-old female who presented with 4 days of chest pain and shortness of breath. The pain was provoked by lying supine and relieved by sitting forward. She also had a history significant for fever and chills 1 to 2 weeks prior to admission. Her past history was significant for type 2 diabetes, obstructive sleep apnea, obesity, GERD, hypertension, autoimmune hemolytic anemia, unspecified joint pain, DVT and pulmonary embolism on Xarelto, squamous cell carcinoma of the tongue, which was removed in 2016, and B-cell lymphoproliferative disorder, for which she underwent treatment. There was no other significant family or social history. On physical exam, she was afebrile, tachypneic with a respiratory rate of 24, heart rate was 100. She was hypertensive with a blood pressure of 160/80, saturating at 95 on room air with a large neck diameter and diminished red sounds bilaterally, and 2+ lower extremity edema. On initial evaluation, her CBC was significant for macrocytic anemia with a hemoglobin of 8.1, CMP significant for creatinine of 1.17 and GFR of 51. Troponins were negative. BNP was slightly elevated in 166. ESR and CRP was elevated at 77 and 96 respectively. Her EKG showed right axis deviation but no signs of ischemia. Chest X-ray showed cardiomegaly with no pulmonary infiltrates, and a transthoracic echo showed large circumferential pericardial effusion with a preserved ejection fraction of 65 to 70% without evidence of tamponade. At this time, she was started on indomethacin and colchicine with a presumed viral etiology given her history of fever 1 to 2 weeks prior to admission. She underwent pericardiocentesis with 1,500 ml drained and JP pericardial drain was placed. On further workup, her ANA screen was negative. Cytology showed some reactive mesothelial cells. Flow cytometry and hematological workup of fluid showed no concerns for malignancy. Her ANCA test was negative. Rheumatoid factor was slightly elevated at 17. Anti-CCP was negative. Beta-2 microglobulin and kappa and lambda free light chains were elevated, possibly falsely elevated due to the ongoing inflammation, which was later found to be negative for amyloidosis or multiple myeloma with negative bone marrow and fat pad biopsies. Her ESR and CRP remained elevated. Our patient began to feel better over the next few days with gentle diuresis with Lasix while monitoring her kidney functions with daily CMPs. Over the next few days, drainage slowly decreased from 600 cc's per day to 380, however, did not reach the goal of less than 50 cc's per day. After 1 week, it remained fairly constant between 70 to 30 cc's, and the drain was eventually pulled out despite not reaching the goal. At week 2, our patient developed a prominent red malar rash and moderate left-sided pleural effusion. Rheumatology was consulted due to high suspicion of SLE despite her negative ANA test. On further workup, a repeat ANA using a human epithelial 2 immunofluorescent test was positive with a titer of 1:160. Her anti-dsDNA was also positive with a titer of 6 units per ml. C3, C4, anti-RNP, anti-Smith, and anti-SSA, anti-SSB, and antihistones were negative. A repeat echo showed trace effusion after drain removal but sustained signs of clinical improvement. At this point, the diagnosis at discharge was massive pericardial effusion secondary to acute flare of SLE, which also happens to be her initial presentation of SLE. She was discharged on 10 milligrams prednisone for suspected SLE with plans to follow up with rheumatology, oncology, and cardiology as an outpatient. So despite high clinical suspicion for SLE, our patient had a negative ANA screen with the ANA Hep2 IFA test during admission. She only tested positive in a repeat test 2 weeks later, despite the high false positivity tests seen with ANA testing. According to 2019 EULAR ACR diagnostic criteria for SLE, ANA titers of 1:180 is used as an entry criterion for diagnosis of SLE, with an evidence that shows a sensitivity of 97.8% with a confidence interval of 96.8 to 98.5 for ANA titers over 1:180, supporting the use of ANA as an entry criterion. This is the latest diagnostic workup and requirement for SLE. Our patient meets criteria with a titer of more than 1:180 in her second test. She also has history of autoimmune hemolysis and joint involvement, which meets the criteria with a score of more than 10. So how did our patient with high clinical suspicion for SLE have a false negative test despite high sensitivity seen with ANA testing? So we were trying to find out some of the reasons why patients with SLE have negative ANA test. Previously, sera was tested using rodent, not human tissues as a substrate for indirect immunofluorescent tests for ANA. The new guideline recommends testing by immunofluorescence on Hep2 cells, which are human cell line, or a solid phase ANA screening immunoassay. However, some SLE centers do not have the access to human epithelial to ANA testing, leading to false negative tests. There has been a growing number of Hep2 ANA immunofluorescent assays that are commercially available, unfortunately leading to lack of standardization among these tests. Also, these tests are labor intense and need skilled technicians for interpretation that can again lead to false negatives. Solid phase assays can have higher false negative results than Hep2 immunofluorescent testing. Patients can also have a negative ANA screen during early stages of their disease. SLE patients who have long-standing disease or have undergone treatment may lose ANA reactivity and become serologically negative over time. Overall, the take-home message is that clinicians should understand the various techniques used to detect the ANA, whether it is a solid phase assay or a human epithelial cells immunofluorescent testing. And in a patient with a strong clinical suspicion for SLE and a negative ANA result, the test should be repeated given that there is still a risk for a false negative test. These are my references, and I'm happy to answer any questions related to my presentation. Thank you.